Yeah. Assalamu alaikum. So, who's asked to present a lecture with the title Ocular Surface Reconstruction. The ocular surface reconstruction, in fact, is for an anterior segment, is a subspecialty by itself. So I try my best just to cover it for you and overall, just to give you a glimpse of what we are doing in this subspecialty. But you're not expected to go into details. At least just what I'm going to present is that thing that you need to know at this level. If you have any questions and the time permits, then we'll take questions at the end. Otherwise, after the grand round, you're welcome at any time. Who's the chief resident? The lady, the one that's supposed to take the keratoconus copy? The one. Okay. So my admin is gonna bring it because you didn't visit our office, so she's gonna bring all the things required, and then you can distribute as a promise. Okay? Thank you. I'll ask you a couple of questions also. It's like an interactive. So I have no financial interest or relationship to disclose in this presentation. I'm going to cover the following: the ocular surface health and importance of early management, in particular of what we call ocular surface diseases and an approach how to treat them, stepwise approach, some of the important surgical procedures that we're doing, and some of the general are doing, like an amniotic membrane, conjunctival flap, limbal stem cell transplant, and the artificial cornea, what we call as keratoprosthesis. So I start by questions. You are in emergency room and you had a patient who sustained a trauma, presented with total epithelial defect in the cornea. For how long do you think you are gonna allow this patient to heal? I prefer this question be answered by first, second year. Okay, total healing. Total coverage of the cornea. How many days? 7 days maximum? 7 to 10. You have experience, so we are answering this one. Yes, we define the persistent epithelial defect if it is more than 10. And we take it extremely serious if it persists more than 14 days. So this is the thing. And why do you think this happened? The delay? Okay, so this is what I wanted to know. So we have an ocular surface. We have the eye that is covered by an squamous epithelium. And we have the cornea, we have the conjunctiva, and we need to have them functioning very well. And we have the limbal stem cell, what she was referring to. The reason behind is that we can regenerate corneal epithelium by having a normal limbal stem cell. So that's what I need to focus. In addition to that, the ocular surface mandates the presence of a healthy tear production and tear properties also, because they have three components of it. And we need to have a good eyelids. So if you have a healthy ocular epithelium, including the stem cell for regeneration and tear films and the eyelids, then everything will be okay. So I just wanted to refresh your mind in case if you haven't taken that one in the basic science course. There is something called stem cell theory. Toft and Fred, they tried to describe how the corneal epithelium regenerates. So like for any one of you would say, if there is any epithelial defect, then the basal epithelium will migrate on the surface, and then the basal, and then it will replace it. So this is one way of replacing it. But the other one is that the movement of the mitotic cells from the limbus, and the limbus where the stem cell is there, and in particular in the palaces of Vogts, okay, where all the stem cells there, so they differentiate into and with the postmitotic figures, transient amplifying cells, and postmitotic cells, and then a movement. So there is a growth or replacement of the corneal epithelium, either from the basal epithelial layer or from the periphery, 360 degree, where you're supposed to have a limbal stem cell. Okay, so this is the way how we regenerate, and we call that theory as thought theory. So every time you have losses, it has to be equal to the ability of the basal layer to regenerate, and also to the stem cell to produce enough transient amplifying cells and postmitotic cells to replace it. So the growth of the healing is going to be, as you can see it, from the periphery. That's why I have to observe the edges, right? And it will be like in circumferential manner. And it will appear more in area where there is a denser stem cell. I've published one review article about the graft failure, and I mentioned something about the stem cells, and at the beginning, you can still just read it. It's a very simple one. So, for the stem cells, do we need to have 100% stem cell? No, like any stem cells in the body, some of them will die for any reasons, and we need at least to have 25 to 33%, third of the stem cells functioning to replace the corneal epithelium. What will happen if we cannot replace the desquamated or damaged epithelial cell? What will happen? What do you think? What is the meaning of conjunctivalization? It's migration of the conjunctival epithelium, okay, including the goblet cells, trying to replace it. So healthy stem cells works also as a barrier. It prevents that growth. So whenever you have a healthy limbus, that this will prevent a growth of the conjunctiva overlying the cornea. So what will happen if you have a conjunctival epithelium covering the cornea? What's wrong? No phallus. You can, but only when you ask resident. Okay, that's a good thing. So we need to have really transparency. This is a second part, yes. We don't need to have vascularization into the cornea. Okay, so these are the two important things. Plus also it's not stable. They break up, you know, it's not normal. The adhesions, the hemodesmosomes and desmosomes are totally different. So the cornea will lose its function, and it's one of the refractive surface of the eye, right? 2/3 of the surface. So, in general, we will say that we need to concentrate on the stem cells health and to prevent limbal stem cell deficiencies, because it is the #1 cause of corneal blindness. So now we just highlighted it. So what happened in ocular surface disease? Ocular surface disease, like, you know, you don't have a normal ocular surface, abnormal cornea, abnormal limbus, abnormal conjunctiva, tear films, and all of them will affect the eye. I'm not supposed to discuss in detail the classification. We're talking about just the management, but just to refresh your mind that the ocular surface can be categorized according to the stem cell deficiency, whether it is below 50 or above 30, and according to the conjunctival abnormalities. Thank you so much. So we have the conjunctiva, if it's normal, or if it's previously inflamed, or if it is still ongoingly, okay? So that's an example of the etiologies that cause abnormalities in the ocular surface health. For instance, severe Stevens-Johnson's, they still have ongoing inflammation. Usually their stem cell deficiencies is more than 50%, and so on. So really we need to know, we don't want to wait until we have the total stem cell deficiencies and severe ocular surface disease. So we need to detect it earlier. So we need to detect the abnormalities in the tear films, dry eye disease. DED is another abbreviation that's well established by Ocular Corneal Society. And we have to detect limbal stem cell deficiency. So I will show you how. And we need to identify the underlying disease to prevent its progression. And we need to reconstitute the anatomic physiological ocular surface as fast as soon as to prevent the recurrence of the causative agents. So the stem cells, as you mentioned, one of the important signs is the conjunctivalization. But for us as a cornea specialist, we don't rely only on that one. We use some stains called fluorescein. So whenever you put a stain, a fluorescein, after a few minutes, it's supposed to clear by itself, right? However, because of the conjunctiva is not normal, as I mentioned, inflammation, and the permeability is different than the cornea and the adhesions. So there will be something called stippling or diffuse permeability of the fluorescein. So you will have this appearance, and this is totally abnormal. Okay, so there is an epithelium coverage, by the way, but if it persists like that one, this is tell you this is an area where there is a conjunctivalized surface. So this is one of the things. So this is one of the diagnostic signs that we follow. But as a clinician also, we don't rely only on our clinical exam. We need to prove it, especially if you are conducting research or you're testing any hypothesis or any treatment. So you need to conduct something called impression cytology, whereby you can take, just strips and put it on the cornea surface and test the corneal epithelium. So it's different than the conjunctiva, and you can detect the goblets. You can use immunohistochemical stains like CK19. It's specific for the conjunctiva, not for the cornea, and so on. Can we isolate stem cell? We can isolate the niche or the ballistic box, but we cannot isolate in particular that cell, because so far we don't have the specific immunohistochemical stain for the stem cells. So it will be, you will isolate it in addition with other cells, but not that one in particular. In addition, also you can do biopsy and can test that one with the microscope. So again, we said we need to rely on objective assessments. So for those who thinks that the Schirmer test is a diagnostic for dry eye disease, please raise your hands. Okay. So I have 2 only. Okay. So what about the fellow? Anwar? It's objective. Okay. So according to the American Academy of Ophthalmology 3 years ago, they removed that one from the list, and now they replace it by something called tear film osmolarity test. I introduced it in KKESH. We have the machine 2 years ago, and there were a couple of projects two so far. I encourage everybody to use it. It's a very important one. You can check the osmolarity, because the osmolarity changes in patients with a dry eye. So we have some figures, more than 280, differences between both eyes, and so on. So and it is a valid test, really. The other thing is that, and actually all patients who are treated in dry eye clinic in North America, they do this test as number 1, and they follow up their patients according to the change in the osmolarity. The other thing that you can ask also in certain patients like Sjogren's, the inflammatory markers, MMB9 and lactoferrin is well established. You can order, of course, the Sjogren test, anti-SS and B, and you can also request some tear film studies. The other thing, the most promising one, this is, by the way, the tear osmolarity test. This is the way how we apply it to the patient. You can have it done also for your eyes if you want. It's in the outpatient clinic. The meibomianography is one of the most advanced one, the machines. It's by Ocular. It's a good one, and it can give you a clue to the meibomian glands, give you the structures of the meibomian glands, because this is one of the most objective one to check it. A couple of slides to show you an examples of common ocular disease in the region. In Saudi, it's trachoma. And all these signs. What is this? Herpes spitz. I remember that many of the graduates, Saudi, who graduated from countries other than Saudi, their program, they were not able to see this until they worked here and they practiced. It's really something unique. And what does it represent? Huh? Follicles, yes, follicles in particular. Okay, chemical trauma, it can happen to anyone. Fireworks, right? Yeah, yes, can. Also, people who are working at home, exposed to reagents, anything. So this is an example of it, and this is stage 4. Contact lens related. Yes, because also it damages the stem cell and also affects the goblet cells, and it causes also inflammations. So that's one of the things. Aniridia also is one of the things. Stephen Johnson, is it common here? Do you see it frequently when you practice in general hospital? Stephen Johnson, Ocular. Okay. Stephen Johnson. So this disease is related to what? What's the cause? Two? Medications. Yeah. Type 4, okay. So, but there is a genetic predisposition. Luckily, we as a Saudi don't have this one. The highest incidence of Stephen Johnson in the world comes from certain countries, in particular Japan. They have predisposition because there is a specific HLA typing linked to this disease. Okay, so that's why you don't see it frequently, but we can still see Stephen Johnson or TNT. OCP, we see it here, okay? So now, the most important part is how to approach patient with ocular surface disease. It's a stepwise approach. It requires multidisciplinary, really, team. It's not only anterior segmental, it's anterior segment, it's oculoplastic. They have to work with sometimes also plastic surgeons in some cases. So, and some immunologists with us. First, we need, this is rule number 1. You need to control inflammation before referring the patient to any ocular surface clinician. This is an important thing. This is in your hand. You can also eliminate toxic medications and control glaucoma before referring the patients, and then you maintain the wet surface. These are the steps. We'll explain each one, and then if you can correct the eyelids and eyelash abnormalities, otherwise refer to the oculoplastic to do that one for you. You have then to refer for us to protect the integrity of ocular surface and promote the ocular surface healing, and we will do our best to restore the globe integrity and to cover unstable ocular surface. Last step, the last one, last of the last, is artificial cornea or limbal stem cell transplant. The reason why I'm saying this is the last, because it's very important when you counsel the patient. When you said that I'm referring the patient to ocular surface specialist or to that clinic, don't please tell him that you require limbal stem cell. That's what I'm going to do, because we do a lot of things before, and we need to say if the patient is qualified to undergo keratoplasty, with or without limbal stem cell transplantation, or artificial cornea. Okay, but usually this is the last, and sometimes this journey takes us like 1.5 years in order, to do these procedures. So suppressing an inflammation, of course, we'll start topically. We usually use steroids. Sometimes we're forced to use a very frequent one. Steroid sparing like cyclosporin, tacrolimus works. Amniotic membrane acute cases. So if you have a patient with acute chemical injury, rule number 1, refer to any surgeon who knows how to do it, please, in the first 2 or 3 days. This is proven by RTCs, so really it's an important thing to do amniotic membrane. And in certain cases, Stephen Johnson is one of them. Also, it's proven by randomized controlled trials. The other way, in some patients, we need to use even systemic, okay? But we exclude some elderly patients. For instance, we use a systemic prednisone in acute stage for almost 3 to 4 months. We start 1 milligram per kg, we taper slowly, and then we introduce the tacrolimus or cyclosporin or mycophenolate. These are the medications that we prefer to use, and that's why I said we need sometimes an immunologist to work with us. So how to eliminate the toxic medications? Try to advocate use of preservative-free medications in these patients. It's a very important thing. We prefer to, there are a lot, but we prefer to use the hyaluronate base or the lipid or osmoprotectants ones like the cystains. In some patients, actually, even we do something we call washout period. So we apply only preservative-free medication for 1 to 2 weeks, every 1 or 2 hours, in order just to get rid from all the toxicity in the eye, especially in patients who are usually referred to us with a bag full of medication. Okay, we don't like using really bottles, especially if the patient is already on 6 medications or more. And one of the most worrisome is the bag. We know what's bag. Yeah, that's a very strong preservative. It's not only toxic to the stem cell, but also it's doesn't allow stable epithelium to heal, because it affects also the hemodesmosomes and desmosomes. It's a very toxic medication. In addition, it irritates the conjunctiva. And there are a group of the ocular surface specialists who believe that there is something called conjunctival stem cell in the fornices, so also it kills it. So nobody nowadays prefer to use medications with back, especially the glaucoma. If you notice, all the glaucoma medication, they're changing them to the purate form. You have to ask about herbs, okay? Don't underestimate that one. They're putting very strange herbs like gurmas, sometimes zamzam, something, they mix it with a lot of things, and this is very toxic to the eye. And you have to also eliminate the cosmetic agents inside the eye for the ladies. Maintaining the wet surface, nowadays we're using serum BSS, and the minimum concentration approved by the society is more than 50. We need to treat meibomian gland dysfunction. It really adds a lot to the dry eye disease. And if you are to use the punctal block, just treat the meibomian before doing that. And the Restasis is one of the first-line treatment for dry eye disease in North America. And nowadays they use it alone or in combination with the Lifacit grad, Zidria. We don't have it in the Gulf yet. It's not yet registered. And it's very effective. The other one that I want to just to let you know that the FDA also approved one of the recombinant human nerve growth factor for patients with neurotrophic a few months ago. We don't have an access to it as a growth factor. It's extremely expensive, but it can be purchased. The other thing is that if you have a lot of mucoid secretions and filaments, don't hesitate prescribing an acetylcysteine. Vitamin A also, we use it sometimes for the keratinization. Then we move to correcting eyelids. There's no point of just focusing on the cornea conjunctiva and leaving the eyelids. Really, we need to make sure that the symplepharon are released. Usually refer this to the oculoplastic, and they do that one by using mucous membrane grafting or amniotic membrane, with or without mitomycin, and they apply rings and so on. We have to avoid exposure, so we have to make sure that the eye closes well. My favorite is the botulinum toxin in some of the cases. Tarsorafte you can do it medial, lateral, temporal. You can ask the oculoplastic. They will choose the one, but discuss it with them. Some people also, which we don't do it, but I've seen people who are applying cyanoacrylate just to close the lids. It's ugly looking. Can tape put up tape on the eyelid if you don't have anybody doing any surface for you, just to prevent melting of the cornea. This is one of the at least things that you can do. The lag of thalamus, the oculoplastic can do for you gold implant, ectropion, because the medication soul will be out, misdirected lashes that would rub and induce more epithelial defects. One of the things also that is established is the use of contact lens. The contact lens is not only for refractive power. We need to stress that nowadays it's one of the modalities that use it to treat patients who have ocular surface disorders. These are special contact lens. They're highly oxygen permeable, and in particular called scleral contact lens. There are a variety of them. If you don't have an access to these scleral contact lens, at least you need to use the silicone hydrogel for recurrent erosions or for large epithelial defect that is not healing, or for exposure, you want to cover it. And this is a list of the companies that are available. Many are here, really, from Bausch & Lomb and Alcon. So we don't use a regular bandage, by the way. It's a specific bandage contact lens that is silicone hydrogel with high decay. Once you put it, you have to make sure that you're putting patient on topical antibiotics. It's important. Okay, you just don't dispense the contact lens without antibiotic. And there are some people who are applying also moist chamber, or to protect the surface if you don't have any access by use of amniotic membrane. the corneal epithelial defect is really very challenging. One of the modality, if you don't have an access to the amniotic membrane, you have somebody who can prepare, an eye bank that you can purchase from umbilical cord blood serum. This is one of the thing. It's like a drops because it have a lot of nerve growth factor, and it works really effectively. This is commonly used nowadays in some countries, especially in UK. As I stressed, I mentioned before that please refer the patient to a corneal specialist for amniotic membrane transplantation, and participated in one of the chapters in the GCOPICS, whereby we discuss how to manage the chemical injuries of the eyes here in KKESH. You can read that one as well. So restoring the globe integrity, whenever we have like an impending perforation or perforation that's less than 2, then you can apply the cyanoacrylate. It's available everywhere. You can apply amniotic membrane multi-layers, and there is something new called umbilical cord patch. It's very thick, it's not transparent, but it works really especially in severe melting. The other non-biological ones, something that are synthetic, that are ongoing in the regenerative labs. One of them is collagen vertigel. We don't have an access to it truly commercially. So this is like in a slide summarizing to you how to cover corneal melt, conjunctival defects, or the scleral defects, and something. What are the materials that you can use? Like, if you have a corneal surface melt, you can use the conj flap, amniotic membrane, umbilical cord patch, as I told you. For the conj surface, you can cover the defects by use of conj autograft from the other eye, or flap from the same eye, or oral mucosa, nasal mucosa, and amniotic membrane. For the sclera, we prefer the corneal allograft, but we can still use the scleral allograft and pericardial patch. There are big differences between these materials. The easiest one and the most accessible one, especially inside, is the amniotic membrane. Autologous conj graft requires a scale. Usually, people who practice oculoplastic and also anterior segment, they know how to do it, but they do it different way. Some of them, they include the tenon, which we don't do, and we prefer not to include the tenon. We call that one Gunderson flap. The other ones, the oral and the nasal. Oral is accessible. Nasal is very difficult, sometimes requires an ENT intervention. Oral is very popular with the oculoplastic, and this is the differentiation between all of these cells. The stem cell, as you notice, it's available only in oral and nasal. However, even if you put an oral, you said, why don't we use the oral mucosa as a source of the stem cell? We have procedure called COMT. We stopped doing it because the stem cell in the oral mucosa will produce a lot of mucoid secretions, and it will be and also it will make the cornea a little bit opaque. The amniotic membrane, you can read the article that I published. Again, it's a review article in the Miejo, summarize all the details of it. It's still applicable to this day, but all what I need you to know is that the amniotic membrane have to you just like 2 sites, epithelial sites and stromal sites, but it have 5 layers, okay? It's type 4 collagen. It's a transparent one. And why we use it? We actually the first in the literature to use it. We used it before the plastic surgeon even used it in their burn unit, because we realized that it promotes the epithelialization, it have anti-inflammatory effect, it reduces the pain, it inhibits angiogenesis, so it reduces the vascularization, and it prevents fibrosis, and it has antimicrobial activity, but it may prevent some of the medications to go through. And the commonest one that everybody is using since 1997 is the cryopreserved. And this is a slide to show you, it's a very thin layer. It depends where are you harvesting it from, okay? If you are harvesting it closer to the core, it will be very thick, and also the timing. So the cryopreserve usually lives for 2 years. So you see, this is you can use it and to check with the wax cells. If it's thick, this is the stromal side from underneath, like what you saw in this one. So it lasts up to 2 years, but the longer the longer the harvest, the harvest time, the less properties that it has, and it become thinner and thinner and thinner. The other way, it's faster, but it's expensive, called Brocaria. It works like a contact lens, and it has a ring, okay, in it, and there are thin and thick one, but it requires a tersaraphy. It's very irritant because it requires, of course, a good phoresis to stuck on. This is one of my patients, and we need again to cover patient with antibiotic. Okay, my patient, this one actually he developed an infection even underneath this amniotic membrane because he was not using the topical antibiotic. So it requires sometimes a tersaraphy just to keep it in place, and requires a deep phoresis. The other one that is available and used by some of the private sectors is what we call the dried one. You can buy it. Even some people are purchasing it, online. But it doesn't have any biological properties at all. It works like a bandage contact lens. Some of people actually, if you see some of the videos, you see them putting it under contact lens, and then just applying it to the eye. This is one of the fast ways. So you put a drop of PSS on this one and then put a contact lens and apply it, but it's really doesn't allow good healing. This is some of the techniques that we're using to put amniotic membrane. So, for instance, if you have an epithelial defect, we usually go 1 to 2 millimeter from the edges, and then we apply the amniotic membrane, preferable with the stromal side down, okay, with the tin or nylon in the cornea. Or we can, and this is we call it inlay technique and the overlay technique, where we can apply it to cover the whole corneal limbus, of course, and the sclera, and we can use continuous or interrupted vicral sutures. Okay, or we can combine both. We call that one a sandwich technique, because usually this one works only as a bandage contact lens, but this one, the first one, it promotes the epithelialization. Okay, so the epithelium will really grow on the top of that one, but here it will be underneath it. This is the difference between inlay and overlay, and this is the sandwich technique. The last one is the one that we use for symplepharon, okay, and with the mitomycin. And this is some of the techniques that we're using. So here we're applying for when a patient who has pseudophakic bullous keratopathy underwent a PKB, failed, and then again corneal edema, recurrent erosions. As you can see here, the eye is vascularized and recurrent erosions. So we just do stromal puncture and we apply it to allow the healing of the cornea, encourage it. Can anybody tell me what is this? A limbal dermoid, yeah. We're using that one also for limbal dermoid. In the past, we used to excise it and we do a PK, but with the amniotic membrane over the past 15 years, we can use a very simple way. We can go very, smooth in OR, and we don't need really to use any donor cornea in these cases. We have to be meticulous. We usually start from the limbal side. We perform periotomy, and then we shave the dermoid, and we try to be careful not to perforate. Of course, we do OCT sometimes in measurements to estimate the depth of the dermoid. Okay, so this is one of the crescent plane. Now we are using even finer than that one. This is an old video for me. And then we can put multi-layer amniotic membrane here. I've used, I think, 4 or 5 amniotic membranes just to promote healing, and this will add also to the cornea structure, so it will become even thicker at that peripheral part. And then we suture it, or we put a glue. Nowadays I'm using glues most of the time on the cornea and the conjunctiva, and I pass only 2 sutures in general, but I use the glue and put it. And this is the example of the patient. So this is multi-layers, these four amniotic membrane, as you can see here, and this is the appearance of the patient, truly. And truly the astigmatism was only 2 diopter, by the way, with this one. It was really thick. I don't have a slit at the edges. This is one of the cases that we're doing, Moran's ulcer, for those who were attending the Grand Round with Dr. Hamad Freg. It's one of the emergency situation that we need to deal with. I mean, in the Moran ulcer, before getting the results of the steroids and the systemic cyclosporin and tacrolimus, we need to interfere in some of these patients. Like this one had 360-degree bending perforation. So we do conj recession resection, and then we apply amniotic membrane. We apply amniotic membrane underneath the resected and recessed conjunctiva in 2 layers, at least a minimum, okay, and this will suppress the inflammation, really, and then we keep it a little bit recessed further. This is one of the techniques that we're using, and this is the example of my patient who was like in bending, you see here, and then this is the picture of the patient early, and this is the appearance. And by the time the steroids, it's working, the systemic steroids 1 month, and the cyclosporin tacrolimus, the eye will be extremely quiet. This is another indication. We use it sometimes in a patient who have ulcerative keratitis or here, this patient have ulcerative keratitis at the periphery, also have surgical induced scleritis. So this patient required a hemicornea transplant, okay? And because of excessive cautery at that site during the previous surgery, the patient developed scleritis also. So, and it was ongoing. So in order to get rid from that one, we had to resect the edges of the conjunctiva, and then we had to apply the amniotic membrane to quieten the eye, in addition to the systemic steroids and immunosuppressant that he's using. And again, you can fix that one with the fibrin glue or with the sutures. And this is the picture of the patient before and after, and all the inflammation in the sclera is completely disappearing. So that's one of the indications. We can use it also, this is another multilayer, don't have time for that one, with a perforation, neurotrophic, multiple layer. What are the complications? This is the most important thing. If you are in an emergency room and seeing a patient who's exposed amniotic membrane, please don't remove the contact lens. That's number one. Please leave it in place, because if you remove it and you don't know how to handle it, you will let the amniotic membrane displace, and there will be failure. So number one, just keep please the contact lens in place. Sometimes there is some granuloma formation, probably related to some of the sutures. Okay, can happen. The dehiscence, either with the patient dropping or somebody is trying to remove the amniotic membrane, which lasts usually 3 to 4 weeks. Depends on the degree of the inflammation. The more the eye is inflamed, the less it will last. Okay. Sometimes there are some hematoma formation intra-op. So we do some massaging. You've seen our procedure is very bloody. So we massage the blood underneath, and we keep little amount because it has fibrin to allow good adhesion. Okay, so this is an example of the dehiscence. So that's one thing. One thing also that we need to focus on when we see the patient following any amniotic membrane, just rule out any infection. Infection can happen even with amniotic membrane at the rate of 1.2, and it can happen from the culture media, from contamination of the amniotic membrane, or it can happen from the sick ocular surface the patient is having and a predisposition. So there was a retrospective study long time ago in 2003. The reason why we conduct that one in 2003 is that at that year we started to use purely KKESH prepared amniotic membrane. So we started the preparation in 2001. It was approved 1997. I remember in 1999, Tseng himself visited KKESH, and we started doing the amniotic membrane using his patent amniotic membrane, the cryopreserved. But 2001, we started to preparing it, and we are certified as an by IBank Association of America. 2003, we're using it purely. At that time, we had a couple of cases of infection, and we wanted to look into what are the causes, okay, and what are the organisms, and we discovered mostly that they are gram-positive organisms, and the rate was comparable to what's been reported. There are cases where amniotic membrane is not advisable, so we don't do it for every cases. Like, for instance, total limbal stem cell deficiency doesn't work if you're just applying it alone with no other thing. Large perforation, it doesn't seal it, okay? And if you have an active infection, we don't do it because this will prevent the penetration of the antibiotics. And if extreme keratinized surface, you have to handle keratinization before, and if you cannot medically, then don't do it because it's not going to work at all. Autoimmune disease, because it requires a good T cell. So some patients with HIV, they don't respond well. I had one patient, stromal ischemia, so it doesn't work. It doesn't work at all. Conj flap. For the conjunctiva, so we have amniotic membrane, conjunctival flap. It's commonly described and used in developing countries who don't have an access to amniotic membrane. Sometimes they use it as an emergency tool. A conjunctival flap can be done total or can be done as a partial. There are indications for each. The one that we prefer to use is named under a person called Gunderson, okay? And the largest secrets ever reported and described by Massachusetts group in the late 90s, and that's why we are still using it. It's a very effective one. We only cover the surface with the conj, but without a tenon. So if we have a good phronesis, we have abundant conjunctiva, we do that one. Partial conj flap to cover impending perforation, something like that one. So, but again, don't do it if you have an active infection or if you have an autoimmune, keratitis like rheumatoid or something. Don't do it because you are transmitting, more inflammatory cells to the cornea. Or cornea perforation, of course, because it doesn't seal it. So total conjunctival flap can be done in patients with the chronic sterile epithelial stromal ulcers, herpetic with no visual potential, patients who have a chemical and total, almost like bicycle eye and non-healing, you can cover it. Neurotrophic is one of the modality, neuroparalytic, painful bullous keratopathy with no visual potential. This is one of the indications that we're using, and of course, anticical eye. And because of the time, I cannot present all the videos, but it's a very simple one. We just measure the white, like for instance, if it's here like 11, then we go here like almost like 13 millimeter, and then we put a mark. We use the local anesthetic to inflate, to separate the conch from the amniotic, and then we just cut the conjunctiva and we fashion it until we reach the limbus, and then we cover it totally with the 10-0. This is how you just cover the whole corneal surface with it. Sometimes we use glue, and we use that one truly in patients who don't have visual potential. As I said, one step in addition that some of us are using is, and I'm among them also, is to use of alcohol. I prefer to use alcohol because I don't want to have any epithelial cells underneath my conch flap. The advancement or tenoplasty, if you want to cover it just partially, if you have like a Dellen or something and you want to just cover it, you can do that one with the tenon, no problem, single pedicle or bipedicle, wherever you describe it. This is bipedicle. In India, they use it very frequent in patients with fungal keratitis. They don't cover the fungal keratitis itself, but they just advance it closer to the lesion because they believe this will allow more treatment delivery when they use the systemic antifungal medication. And they have an outbreak of fungal keratitis. Complications ranging between 10 to 11, as I said, flap retraction, hemorrhage, epithelial cells, ptosis. The appearance is going to be like a grayish. It's not like amniotic membrane. You saw amniotic membrane with the time become transparent. Insufficient glaucoma penetration. So this is an example of one of the patient who had a herpetic, and underwent multiple BKs and then no visual potential, advanced glaucoma. So I decided just to cover, and this is the appearance after I did the Gunderson flap. Stem cell transplantation. Stem cell is been described since 1980s. And the first one was described by Kenyan group, Massachusetts. It was named as conjunctival limbal autograft, the CLAW. This is the most simple one and the most promising one with a very high rate. So you take stem cell from the other eye. So simple. Only if you have a disease that affects one eye, not two eyes. Okay, and in young patients in general, because most of the elderly, they have a bad stem cells in the other eye, and you may jeopardize the other healthy eye. So we call that one conjunctival limbal autograft, CLAW. The other one, conjunctival limbal allograft. So we take the stem cell from a living related. Okay, this is one of the things with, and usually we do HLA typing, or you take it from the cadaver, from the eye bank, but with the time they transport to any cornea to you, usually most of the stem cells are gone. And we call that one CLAL. Okay, so this is the second procedure, CLAL, with C. The other one called keratolimbal allograft. So you cut it from a separate donor and you do it multiple pieces. Okay, so this is one. The one that is very popular is the CLET, the ex vivo cultivated limbal epithelial stem cells. Okay, so we had 3 cases here in KKESH. Our stem cell lab is now under renovation, where you cultivate or you grow stem cell from the other eye in the lab, and then you deliver it with like an amniotic membrane or some people are using even contact lens, but we prefer amniotic membrane as a transport media, and we put it on the diseased eye. The one that we stopped doing is COMT, where we use the oral mucosal stem cell to replace the limbal stem, as I told you. So this is the CLAW. So we usually take a pieces from the other eye. Okay, so this is the way we prefer to do 2. Some are doing 1 only. They transplant only 1 quadrant. You don't require to have any systemic immunosuppressant. That's why it's very promising. And this is an appearance. So this is taken from so this is the other eye. So you take this one big block from the limbus, and you also take some part from the cornea where all the stem cells are there, and you transport it into this region. Some that will take 2 pieces, or others that will take only 1, and preferable that you cover it with the amniotic membrane, and then you put a bandage contact lens, and then wait. So these stem cells will replace whatever been damaged here, and the patient will have less symptoms in the future. This is another patient also where we remove the conjunctival, abnormal conjunctival epithelium with fibrosis from the eye, and we transplanted it. Okay, and we put an amniotic membrane and look how the appearance. One of the resident thesis actually, Dr. Ammar Mahmoud, who's the former, I think, medical director in Dish. So one of his theses that he did with us was to study the outcome of the CLAW in KKESH, and also the CLAL, which is taken from the living related. And the success rate was 87, comparable to everywhere in the world. And then the CLAL, is because it requires systemic immunosuppression, 22%. And this is well known. In general, most of these stem cell transplant, they don't survive more than 5 years, because they will die. You cannot maintain them. So this is the longest success. And the use of systemic immunosuppressant is risky. You have to keep it in mind, the age. You have to keep in mind that it may cause lymphomas, because we're using a strong immunosuppressant in living related. So this is an important to be discussed with the patient. But it can help them to work, especially if it is the only eye for them. The other procedure, so once we are done with the stem cells, we transplanted it, or there was no major issue of total loss of stem cells, there are still some healing ability, but the cornea is opaque because of the trauma or anything, you can do keratoplasty. So this is the last step. So we'll do keratoplasties, provided that we can allow the stem cell of the patient to cover this transplanted tissue, whether it's a BKB or lamellar. So there is no point that you're seeing patient with total stem cell deficiency. I said I want to do for him BKB. How come his epithelial will heal? So this is a very important thing to know. Sometimes what we do is just we put the PKB because it's a tectonic if there's a large perforation, and then we cover it with the conjunctiva or any conjuflap or something like that one. But we don't do it if you have a total stem cell deficiencies or totally inflamed conjunctiva, like in Stephen Johnson or something like that. So this is the last resort. We don't like to use it acutely. The other one is the keratoprosthesis, and you know that we have a clinic here in KKESH introduced this year. And the commonest keratoprosthesis being used is Boston, type 1. Type 2, we stopped using it. And there is a third one that is still being done in some certain area in the world, in Spain and also Singapore, osteodontokeratoprosthesis or osteotibial keratoprosthesis. And the indications, usually you like to use them only in certain conditions. These are artificial corneas that have a risk also. So we do it in high-risk patients where we know that BKB will be failing, okay? And we can use them in patients who have also tube surgeries, and we know that they have problem with their tube surgeries, always touching especially in patients with the chronic angular closure. But if it is under control, because again, this will cause something called glaucoma escalation and will induce secondary graft failure. So probably the K-Pro will be the best thing for these patients after repeated BK. Ocular surface failure, limbal stem cell deficiencies is one of them also, but not with keratinization for Boston type 1. We need to have an adequate visual potential, and we have to check the nasal projection in these patients. Many of the time that the keratoprosthesis are being done together with the glaucoma surgery, because most of the time they have secondary glaucoma. It's not really suitable, the Boston K-Pro, for advanced autoimmune color disease at all, because the artificial cornea will exclude. It will not blend with the patient eye. Again, even patient with end-stage glaucoma, it's not going to work. You cannot provide any vision for them, and this is how it looks. So this is the corneal donor, okay, and this is the blade. Okay, and there are fenestration to allow the nutrition. Okay, and this is the transparent structure, which is made from like a BMA, and this is the appearance, and there will be limited visual field, as you can see here. And you can see we usually apply bandage, contact lens, most of the time cover patient with antibiotic. The complications and endophthalmitis can happen anytime, can happen from any infection from the cornea around it. Okay, so that's why I said we usually put the patient on long-term antibiotic, and we alternate. We have certain regime. There is something called retroprostatic membrane. So behind this one, there could be like a membrane, like a BCO. You will see it. That prevents the view. We can do YAG for it. Sometimes what happens is the cornea melt actually around this implants, or so we need to put a mucous membrane graft and so on. The other one that we stopped doing, this is the type 2, the extrusion rate is extremely high. The previous ones, so like Bentucci's and there are a lot of keratoprosthesis that have been described, but the extrusion rate is very high. And this is the appearance of these implants. The one that you may see coming from Singapore and Spain is called osteodontokeratoprosthesis, where they use the tooth or the tibia bone, okay? And as like a media, instead of using the corneal donor, okay, and they fix to it a transparent glass This is the one, okay? And they use a mucous membrane, and they usually do that one in 2 stages. So first they cover the eye with a mucous membrane, and they put the teeth, and then they draw into that teeth, and they fix this plate. So simple. So these are the procedures that we can do in advanced stages, and I think now we are reaching the time. It's we have 5 minutes. Yes, you can ask any questions. Yeah, go ahead, Inmar. No, when you have a severe tissue loss, like stromal melting, just putting one layer is not going to have, so it will work like additive tissue. So it will increase the thickness of the cornea until the keratocytes starts to migrate, because also keratocytes is also in regenerative phase. So with the time also they will grow and they will replace whatever dead. So this will allow the peripheral cornea to become a little bit thicker than usual, because we don't want to see anything like a thin cornea at the periphery. It will have like a Dylan-like effect. And it will induce astigmatism, so there will be a lot of problems. So usually whenever we have an ulcer, a deep ulcer, we prefer to use more than one layer. More than one layer. No, it has nothing to do with recurrence, but it's reconstruction, a form of reconstruction, yeah. Additive tissue, yeah. Yeah. Okay, that's a good one. So as some of you said that you need to see, when you follow up the patient, you need to see a response, right? So if you see in your follow-up the patient is healing, the edges is clean, you know, you will see they're not supposed to be rounded shape. They have like a vortex pattern, so they will have some projection in it, okay? This will give you clue that the patient is healing. But when this stops, you follow up the patient and this stops, it's the same size, because you're documenting, you're measuring, right? You're measuring the longest dimension with the shortest, with the slit lamp. This is the usual for you. So let's say it was 7 by 2, and for 3 days or 2 days, it's still the same size. The edges are roundish. They're not normal. They don't have that projection. So now you question what's happening with the healing pattern of the patient. So you need to really to help that one by using the serum BSS, the growth factor, and it will help. And you have to revise the management way. Maybe there is something rubbing. So it's not only the serum BSS. Okay, that's when you have to counsel. Or of course, if the epithelial defect persists, as we said, more than 7 to 10 days, really you have to ask for help. Any other questions? Yeah? Yeah, Omar.
What's the harm to use the serum BSS without presuming late?
Correct. True. They usually do it with the serum BSS. We don't like to use it first for the cost effectiveness as a first line therapy. This is well known, right? Cost effectiveness and accessibility. So you don't prescribe it immediately as a first line therapy for a patient whom you would expect a healing. But as you mentioned, if a patient is having severe sick surface, neurotrophic, like diabetic, okay, and there are signs that the patient is not healing, there is no harm of starting it when he presents to the ER for the second or third visit, because he's a frequent ER attendee. But again, we need to revise what is the causes and how can we help preventing that one. Maybe sometimes he's having epithelial basement membrane dystrophy. They have abnormality in the adhesions, because all the diabetic also they have abnormality, so we can help by doing stromal puncture, right? We test the healing pattern. Sometimes when you put a fluorescein, that will give you a clue in diabetic patients. Sometimes there is epithelium, but it's not stuck, so you have to debride it and allow healing by stromal puncture. So don't rely only on one medication. So serum BSS can be used, but remember accessibility. You need to have a good lab to make it for you. So there are people who can do it, compounding pharmacists, but it may not have all the properties needed. And the second question is about the conj flap. I know there are some of the, and also Dr. Fawaz will tell us, some of the consultants who are still doing it, but not in acutely infected cornea or keratitis, I would say, acute infection, in partially treated, but not acutely. Like for instance, if the patient just presenting to you and you're starting his fortified antibiotic for 1 or 2 days and you just think, oh, okay, let me cover it, this doesn't work. Usually they treat the patient for a certain period of time on antibiotic, they place them on certain, and then they put it on the top with partially treated. But of course, not going to be fungal or something because there will be endophthalmitis. So at least you make sure that you control partially the infection. I'm not among that group. I know do that one, but he used it after 3 or 5 days of intensive antibiotic that is sensitive to the organism. Okay, this is the question because of the endophthalmitis risk. Any other questions? That's it. Okay. Thank you for your kind attention. انتي نسيتي وانا ما نسيتك.
هو
ما
عندنا
جيتي.
all the slides mistakes
لا انا جيت لك من هي الاول خفت عليك من غيركم. نسيتي لما كنت انا ضيفه. ضيفتهم وما اخذتوها. قلت اسكت.
لين كيف حالك؟ هذا الياسمين؟ طيب 3 minutes. دكتور فاتح
معك؟ لا مو معك.
الا معك.
إلا معك.
لا بس كان متأخر. عندك صار دخل شوي لكن
محاضرتها
بس الحين الحين يدخل دكتور باتريك. Sam, I have the adapter.
Good afternoon, everybody. Welcome to the Grand Round. Today, Dr. Akili, who is consultant in the vitreoretinal division in King Khalid Eye Specialist Hospital, and who is also Associate Director of the Outreach and Eligibility Department, will talk about artificial intelligence in ophthalmology. And as far as I can understand, Dr. Akili got into this topic while being responsible for the telemedicine program of KKESH. Welcome, Dr. Akili, and we look forward to your lecture.
Thank you very much, Dr. Patrick. ماجد بنزلها شوي. طول هذا. Okay. السلام عليكم. I'm glad to have this opportunity to present about this very interesting topic, which is becoming a new passion of mine. And I would like to start by reading this statement because it reflects a lot of probably the 80s and the 70s born generation about what we think about AI. So this is Alan Turing. He was the father of what's considered the modern computer. So he says it seems probable that once the machine thinking method has started, it would not take long to outstrip our feeble powers. They would be able to converse with each other, to sharpen their wits. At some stage, therefore, we should have to expect the machine to take over. So what is AI? AI is a system's ability to correctly interpret external data, to learn from such data, and to use those learning to achieve specific goals and tasks through flexible adaptation. I think this definition actually is something I don't think that I can do very well myself. So I would encourage any one of you who's here just to try and log on this website and see if what's the situation of our job in the future. Okay, so will robots take our job? It will show you interesting findings. So bear with me on that. Okay. The good news is, at least for the time being, anyone knows who this guy is? Have anyone come across him? Okay, this is the first AI minister in the whole world. He's in the Emirates, and he's Dr. Umar al-Ulama. So at least AI had brought one job that we know of right now, okay? Okay, things that you need to know about AI is that AI is a very old concept. It was invented around 1943, and in medicine, actually, Gunn was the first to successfully use the AI technology in surgery. And the important dates for us as ophthalmologists, as physicians, would be that the first FDA grant for AI medical technology was given in 2017, and in ophthalmology specifically, the IDX software was the first FDA cleared AI system to automatically detect diabetic retinopathy. I think it's stuck. One other important date is the involvement of Google in AI, where actually they had a very famous company called DeepMind investigating and looking into different kind of data in the eye as well. So the MIT management, the Sloan School has showed this report where they actually talk about the huge interest these days in AI. So the research in AI drastically increased around the world. Particularly in China, it's 150% more than the past decade. Research was focused on different fields: technology, humanities, and medical science. And most importantly is that machine learning remains the most common focus of research, followed by neural network and computer vision. And enrollment in the schools is on the rise. If you have any kids, you should let them know about this because everyone is going in this direction. So what is machine learning? Because this is what we actually care about in our models in medicine and ophthalmology specifically. It's a process in which machine writes its own programming and learns to complete a task on its own. It uses training data set and validation data set. So if it has, okay, so I'll give you an example. In the case of diabetic retinopathy, we have this data set that we examine, and then the algorithm is created and it tests those data in relation to the ophthalmologist. Dr. Patrick, I think this is the only picture I've seen you wearing a tie. So I was glad to find it. The ophthalmologist will look at the data, and then he would be the gold standard, whether it's the best. It goes and it's accurately detected as diabetic retinopathy in this case. If it does not, or if it gets a high rate of error, the machine will reevaluate its algorithm, and then will go in and change its ways, the things that actually measures the internal mechanisms within the algorithm itself. The machine is then fed the same training data again and produces the answer set of answers. Produces a new set of answers. This process occurs indefinitely, so it will remain studying the same data until it gives you a plateau or the desired output that you actually want. And in the final sensitivity and specificity and accuracy scores can be checked, and then you'll test it again, validation data set for external validity. So what made this interest in AI these days? AI, I said, was here for a long time. Actually, machine learning was coined in the 50s. And what made this happen now? So the grand AI discovery was deep learning. And this is that you could take a huge data with single domain and learn to predict at superhuman accuracy. This small graph here shows you the state of things in the past. So we used to have the approaches of other approaches of AI, which actually was evolving in a steady pace, and then the neural network, which is a part of machine learning that is deep learning, has evolved. And the other thing that's very important is that we actually have amount of data that exponentially increased. In the past, we used to have data that was not in the form of digital data that we can access, and these days we have a huge amount of data in all fields and ophthalmology. So what is machine learning algorithm? I talked earlier about machine learning, that we actually would teach the machine how to understand the image of a diabetic retinopathy. But there are different ways to do that. You can teach, you can do this through unsupervised machine learning, which is something that that's used in many fields, but in medicine and specifically, we would rather have something that's supervised. And under the supervised machine learning, we have the neural network, which can be either a simple one or a deep learning neural network, which is what we call deep learning. So this is an example of a set of machine learning set which a part of the machine learning, which is supervised learning. And you can see this regression here, which actually is shown on 2 planes, and then you can start to wrap your hand up around this. But when it starts to get on different planes, it gets a little bit complicated for your mind. And then when you get multiple planes of data analysis, it's something that your mind probably cannot comprehend. A convolutional neural network is one of the types of the neural networks, and it starts without any tuning and gives random results, then progressively learn the combination and the permutation of important features while learning to ignore important features or unimportant features like artifacts. These are the layers that are within the deep neural network where actually the data is interconnected and pass through different layers before you get the end or the output layer. So back to medicine. In medicine, as you can see in this pie chart, the largest part here is actually the part that's on diagnostic imaging. And diagnostic imaging, and specifically on screening tools. The reason is because this is the low-hanging fruit that everybody can wrap their minds around it, and it's a way that we can start and get good results and then go into more complicated and deeper layers. There are other modalities like electrodiagnosis, genetic diagnosis, and clinical labs. So why the eye? The reason is very simple. These are all examples of tests and data points that we can acquire from an eye. So actually, the eye can be readily and precisely imaged, and there are huge amount of data from the eye. We also have established models of telescreening, so you can screen through different modalities and get a huge amount of data rather than having all the tests done in one place. This is in big programs like NHS and VA in the States. Okay, and there's another problem which we will come across in our experience later, which is the need of a reading center, which by itself can be a weak link in the process of telemedicine. So how can AI help ophthalmology? AI-based grading algorithms may be used to identify which patient should be referred to ophthalmologists for evaluation. It has already demonstrated proof of concept in medical fields such as radiology, pathology, dermatology, which are deeply rooted in diagnostic imaging. The need for workload reduction. Our clinics are burdened with long waiting lists and patients unfortunately arriving at late stage of their diseases. The algorithm can be run on personal PCs and smartphones with average processors. It can improve the sensitivity and specificity of a risk patient detection and promote personalized medicine. An example of that would be later if we have a special lens that can help you actually image your retina, and then not even needing to go to the physician's office. It can also AI can also recognize disease-specific patterns and correlate novel features to gain innovative scientific insight, which is something we'll discuss later. So, diabetic retinopathy. As you will see, the big breakthroughs in this field are actually mostly in diabetic retinopathy, and the reason is that deep learning in disease is really good once you have 10,000 image. I don't know why I wrote times, but image, which actually you can read. And after that, you will be in a, let's say, safe to say that you have a very good algorithm or a model. Diabetic retinopathy screening has been proven to be cost effective. Deep learning is good for the lack of supply of physicians. An example of that would be in India, where actually there are 127,000 ophthalmologists short of the number that they need. And for this, they have 45% who suffer visual loss before even presenting. In addition to the strength and potential for these studies to be better than screening guidelines recommendations for regular diabetic screening, diabetic retinopathy screening. So again, I'm going to go through what we have, and then we will go afterwards to what will be very good to have in the future. What we have now is this software. It's called IDX. I'm sure those of you who have been to any meeting have seen its booth. It's in everywhere. This is a software that actually gained FDA approval in 2018, and basically it was developed. They had automated analysis of retinal fundus, where they actually coined a lot of the terms that's used now in how we actually look at analysis of fundus photos. So it started in the early 2000, and in 2008 they had a system that reached an area under the curve of 0.84, and in 2016 they actually managed to validate it through a data set, Mesidor 2, and then afterward they showed the results, and actually they developed the classification of diabetic retinopathy screening, where they actually are using in their own machines. So they call it referable diabetic retinopathy when there is moderate NPDR, severe NPDR, PDR, or diabetic macular edema, or vision-threatening diabetic retinopathy, where they're actually severe NPDR, PDR, or diabetic macular edema. And they've shown a specificity and sensitivity of 97 and 87% respectively in the referable diabetic retinopathy, and 100% sensitivity and specificity of 91% in the vision-threatening diabetic retinopathy, where actually they did not miss any case of diabetic macular edema, which is an interesting finding by itself, knowing that they actually screen diabetic fundus photos. So they achieved a de novo pre-market review pathway, license, and it's actually available in the market. And the idea is very simple. You show the picture, the algorithm looks at the model looks at it, tells you this is referable, non-referable, and the patient gets the diagnosis on spot. Okay, the other model, which is becoming what we see in most of the meetings and all of the media hype is about, which is the Google model. Google actually have two models. The first one was they always refer to as the JAMA paper, which is a tool for detection of diabetic retinopathy, and they used deep learning models, and they show here that they actually have these are how the ophthalmologist had their sensitivity in comparison to the dark line here, which is actually very comparable. Basically, they adapted a deep neural network where they actually have 26 layers of CNN, the convolutional neural network, which analyzed and showed different stages, as we know, as diabetic, no DR, mild DR, moderate MPDR, and the rest go on. They identifying diabetic so they identified the diabetic retinopathy through fundus photographs, and they did this against manual grading. They had 2 validation sets defined as moderate or worse or referable macular edema by a panel of 7 US board certified ophthalmologists. The first set was around 9,963. And the second set was a larger one, and they describe a lot about how actually the AI learns about how it views the fundus fundus photo, because we need to know that the AI is actually does not have a preconception about what actually is an optic nerve or macula or the blood vessels. So a lot of the work that was done is to actually familiarize the model with these functions. And they call this housekeeping function. And then they took the AI through 130,000 images, and then they validated on the 1/3 of those images. A very interesting picture is this one, because so this is how you view the fundus photo, and then after analysis, this is how the AI looks at it. And what's interesting here is actually that this is something that is an artifact, this one as well, and then the machine recognizes it as an artifact, which can be something that an untrained eye would think of as a lesion. The big event that happened and all the hype was about was this article, which is the one that was published in Nature Medicine, and this was a study that was based on OCTs. So basically what they did is that they would take a set of OCTs, and then because you have a lot of data that you can get from an OCT, so looking at all the data at once can give you different results that can be confusing. So they manually segmented the areas where actually the pathologies are. And then after they segmented those manually by the physicians themselves, they showed it to the machine. And then it understood that segmentation of the data in this picture would mean that you can see something through it. So it's not just basically seeing the whole image as one, but getting each segment on its own. And then each segment was an example of a segment issue that they had was an example of a disease and the OCT. So this is why where you see those lines here. And then they defined those cases as urgent, referable or referral suggestions for whoever does this imaging. So basically, you have an OCT again. The OCT is looked at by the machine, and then it will give you a recommendation whether this patient needs urgent or semi-urgent or just needs no follow-up. And basically, this is how the machine looks at the image. This is how it's segmented manually, and this is how the machine looks at it. So basically, you can see that those actually are exactly the same. And then they took those results, and this is the interesting part, is that they took the OCTs themselves that was analyzed by the model, and compared it to an ophthalmologist who had seen probably the patient and looked at the fundus photos and even read the notes of the patient. And they compared how they did in comparison to the model. And they saw that the model, based on the OCT only, actually predicted more precisely the degree of referral urgency that the patient needs. Probably this will be shown here even better, where you actually see the OCT here. This is the model, and how it behaved, and this is how the percentage of how significantly better it did. And compared to the first retina specialist, it basically, who had OCT knowledge and had the fundus photos and knew the patient or saw the notes of the patient, they behaved the same. Whereas the other specialists actually did worse, and optometrists and general ophthalmologists even did even worse than that. So this tells you that actually the machine can even detect things that you don't see on the exam from the data that it acquires. These are other examples of other uses in retina where they used it for as a method to detect macular edema. And there are a lot of studies in AMD where they tested it using fundus photos and OCTs as well. And MacTel. There is also a study on AI on ROP, which showed very promising results. Also in glaucoma, there is the rationale of using AI was to detect glaucomatous disc, which has manifested visual field loss. So you look at the fundus photos, and then you could predict from the fundus photos how a visual field would look like. It's also using AI to determine which disc will progress, because you have those patients, and basically you know some of them have the same appearance of the disc, and then they will progress at certain different rates. They also looked at the idea of Kalman forecasting. Kalman forecasting was the method they looked at when they were trying to get to the moon, and basically to target what do you expect in terms of the IOP on the long term. These are all the software that has been developed for fundus photos only, and these are also software that have been developed for OCTs. Also in anterior segment, there are different software that has been models that has looked on different areas in dry eye and refractive errors and keratoconus. And an interesting one would be the refractive error, which actually was based on a fundus photo. So basically, the fundus photo through it, you could tell if a patient is a hyperope or a myope or has astigmatism just based on the fundus photo itself. In pediatrics, they actually used it to detect which patient will actually develop amblyopia from a cataract and which won't, and basically base their decision on that. And in addition to those, these are fields that everyone is thinking of. There are actually discoveries that no one has actually thought of, which basically is where you actually use the data and the analysis of the data to look at biomarkers that probably as a physician you never thought that they are that show any disease. And this happened in some of the neurological diseases where they looked at fundus photos of patients with Alzheimer's and Parkinson's, and they would tell in addition to the OCTs, and they would tell how they can diagnose those conditions through the OCT itself. There's also a big study about cardiovascular diseases risks, where actually you can predict from a fundus photo whether the patient has it. And this was done by deep learning. There's also a lot of talk about deep variant, which is a model that was developed by Google to look into genetic variation and correlation to clinical diseases. Okay, so basically, we are actually in an interesting time in terms of what AI can achieve. This is not just in terms of eye health or medicine, in terms of what we can get in life in general. And the problem is we always, as humans, tend to overestimate or underestimate what would happen through any new technology. So basically, if you look at things from the way they are in the past, depending on how you look, you would think probably this is a very interesting times and everything is going to change. Or if you're a pessimist, you think that these are just hypes that people are actually just interested about, and in the long term, they will just fade away. And there's an interesting thought on that, where actually you think of progress as an S-shaped curve, where you actually get those new paradigms, and in the beginning you have very high expectation, but they're like plateaued, and then suddenly something opens up, and then you get this spike in progress. And this is what's happening now with the AI and machine learning specifically. And then with time you start to get to a plateau again, and then probably you look for another area. So we talked about a lot of nice things about AI, but what are the challenges that we actually are facing with this kind of technology? There's a very famous term that everybody's using, which is machine learning is like a black box, because data goes in and then data comes out. You don't actually know what's happening inside. And this is very challenging when you look at it from two aspects. The first aspect would be if you're a person that's skeptical of everything, and you have like a conspiracy theory where you think that someone is actually playing with the algorithm, and that's why you're getting those results. And the other part would be in terms of scientifically, because we have a scientific method where we actually can produce results and then test them and then show that they actually are true based on the scientific method we're using. But in a lot of cases in AI, you don't find this. And this can be difficult to replicate in clinical studies in general. But there has been things there are things that has been done on that, because some of the AIs are built to be explainable, and then you can through it interpret some of the data in those kind of AIs. And actually in the deep learning, in the DeepMind model in Google, they showed some of the pictures, and they were showing how the AI is actually looking to a picture where they actually focus on certain areas, like if they have image recognition which looks into dogs, different kind of dogs, and then if the AI suspects it's a certain kind of dog, it would look at the mouth, or it would focus on that area. It's like a heat map where actually the AI will look at. And so this can probably is a very early time to talk about this, but it's a possible way to solve this issue. Another issue, I don't know if any of you have seen this before. Okay. What is it? You know what is it? Exactly. They actually take your fundus photo, yours. So they which is very interesting. So basically, what the thought on this is that actually the fundus photo is actually like a fingerprint, which is actually unique for each individual. And if you think about this in terms of privacy, it is a way to look at it. There is a way to look at it as a fingerprint. So if you have your data taken and then analyzed by different entities, different companies, and who knows where, you basically are exposing yourself or your privacy to others. Of course, whether this can be linked to you individually is something that is not at this stage possible, but you never know. So iris scans are ways to actually you go into a country by iris scan. So why not fundus photo in the future? So privacy is a very big issue in dealing with machine learning and the big data that's generated from it. There is also a very nice article that was published in the AMA Journal of Ethics, where they actually looked at the ethical part of it. I would recommend any of you who's interested in reading this. It's a very nice article, but they looked at it in different ways. Part of it was privacy, but one interesting part was actually teaching the new generation of students or physicians. So if you teach them how to use the AI, would they actually need to learn a lot of the stuff that actually need to be learned? And this can be a challenging thing to look into in the future. Another big issue is the kind of data that you have. So a lot of the data that we have can seem good. So we have a big amount of let's say fundus photos in our servers, but what actually, if you look into them, are these data that you can use? There are other examples of that in terms of statistics, when you look at different kind of statistics in different fields, where you actually whatever you put in the system, if it's not accurate, you will always get false results at the end. And finally, in terms of challenges, is the trust. So, robotic surgery is a way that's been. This idea has been started, but basically, would you trust an AI without any physician's opinion to look at your investigation and say that you're okay or not okay? I think in medicine we actually have reached this threshold a while ago, and we actually depend a lot on some tests where actually it just recommends for you whether you treat or not, whether you understand what's in it or not. But it's a challenging thing for a patient probably. And at the end, I just want to talk about our experience in KKESH. We had a pilot study which was a validation of a novel fully automated disease grading software, which supports telemedicine-based diagnosis of sight-threatening condition of diabetic retinopathy. This is actually done through rigorous screening and early detection of diabetic retinopathy in patients with diabetic. Generally, the idea of screening diabetics is always good. We have a big population in Saudi Arabia, and the need of doing a dilated fundus exam has created a huge amount of waiting list, and this actually ends up with the patients turning out in a very late stage of their diseases. A telemedicine screening program will be a very good tool. However, having this kind of program will also create a backlog of patients who actually need to be their images to be read. Whether you have this amount of physicians that can do this is a very difficult thing to actually answer. And having a reading center, we actually train non-doctors to look at images is a challenging task by itself, because most of those people, when they reach a certain stage, of understanding, they will look into probably another less boring job to do. So generally, looking into a model of machine learning would be a good supplement for such a telemedicine program. So in this pilot, we included adult patients with diabetic who are diabetics, and with clear media, and compared them to the gold standard, which is actually two ophthalmologists who looked at the same images. And the degree of agreement between automated analysis and manual grading was quantified and assessed using statistical analysis tools, and sensitivity and specificity was considered significant if it was less than 0.05. In this small pilot, we actually had 101 images, and there was 8 images that was excluded due to poor quality based on the AI grading, and it was removed from the calculation. So compared with the gold standard, the sensitivity of the detecting diabetic retinopathy was 97.7, and all the images that had no disease were actually graded correctly through this software. So the AI accuracy was found to be 97.85 compared to the gold standard. So it's basically a promising pilot, which actually will help us in probably looking into a bigger sample and then having a better validation for this kind of software. But it was something that's very readily available and can be used, and probably would be a very good tool to use in a telemedicine program. So what's the future? So we've heard a lot about what AI can do. However, there is things that we as ophthalmologists are very interesting to us, because we have a lot of images and we have a lot of data, and most of those images are basically stored in a way that can be very easily accessed. So the future can be would be into looking into those data and studying in different ways, because what we saw from that case of actually getting to diagnose hyperopia or myopia from the fundus and knowing if a patient has a high risk of cardiovascular disease through just looking to a fundus photo, is that there are things that we actually don't understand, and probably a machine that looked into much higher number of eyes than anyone would do in his lifetime would be able to detect and then probably look at. I remember probably Dr. Sosa Nwelati admires Dr. Gass because he had this very sharp eye that looks into unique things in each eye and then detects those. Probably an AI with who saw the number of patients that he saw, or maybe 10 or 100 or even 10,000 times more would be able to detect other things that he was not able to see. So this is a very interesting times for ophthalmology. It's a simple way to do things. We just need to have the interest. There is no much that you will spend doing it. Basically, what you need is a computer that has a GPU, which is something that you can buy on your own dime, actually, like a friend of mine, Dr. Adi, actually did. And then probably you would be able to look into the data yourself and then discover new things. You don't need to have a lot of people working for you and looking into files and digging into a lot of the data that you need in files. You have a lot of the data in front of you, and probably you could discover something huge in the near future. So I would encourage all of you to look into this. Probably you'll find something that interests you. I don't know why I put this one, but I think I was at the end of the night and I was not. So basically, the risk of something seriously dangerous happening in the 5 years time frame. So basically, this is how most of the people in the West look at it. I hope that we are not looking at it this way. Basically, people are afraid. People are thinking that it will actually control us. I think we are at the cusp of doing something great, and we can utilize this technology to do it. So again, at the end, this is an invitation for any of you who's interested in any of those projects to read about it. Come to me, talk to me. Maybe we can think of something that we can work on, and probably we get something nice happening. Thank you very much.
Thank you, Dr. Akili, for a very inspirational lecture and very interesting. Any comments or questions from the audience?
Thank you, Adel, for the nice overview. I remember in one of the SO meetings, one presenter mentioned a study that he reviewed for ophthalmology, and in that study, the artificial intelligence that they used was able to detect if the patient was male or female from the photo, and in 97% of the time. So he, as a reviewer, he said, I don't believe this, and I will send the authors my data set, and I will see if their machine will be able to do this. And
He's a smart
indeed,
guy.
it did the same thing. It tells, in 97% of the time, it can tell if it is a male or female, and the age as well. So my question is, what does it take to develop artificial intelligence software? So we can develop something here. We have the data, definitely, but what does it take to develop one? We don't want to buy an artificial intelligence.
So actually, there is a very interesting article that that talked about AI that writes its own AI. So basically, I mean, now it's when you go to the meetings, you see people talking about ophthalmologists just writing a very simple code and creating a model that actually they're using themselves. It's a very simple task. Myself, I'm not a coder, but I read recently a lot of books in Python, and it's not that complicated. This is if you want to do it yourself, which is I mean not a very I mean it could be for a person who's interested, but having someone who has the very simple knowledge of writing a code. And a very simple PC with a GPU with all this data set. The only problem would be the issue of privacy and how we can deal. So if you actually have those very simple tools, the PC, and someone who knows how to write codes, you can do it in your own setting. And actually, I've been approached by some I mean college students who actually are very interested in this kind of projects, and they actually would want to volunteer their time just to work on stuff like that. So I mean, I think just having simply a PC with a GPU, and you'll be okay.
Thank you, Adel. This is very well organized talk and focus in the most interesting subject for the future. We were on the United States in the American Academy last, and most of the session were focused in the artificial intelligence. And we found a lot of ophthalmologists really starting to deviate from the daily practice to go and to work with the computer, specialist, how to starting to make the combinations and to get this programs. I think the future of artificial intelligence is important not only to detect things that we are know, but how to help us to make the journey of the patient short from starting screening and then make more specialized programs in artificial intelligence to give you the real diagnosis. We are not talking about treatment now. Till now, we're not reached that point. We have robotic, we have things, but we need to have a screening program, which is now most of the artificial intelligence is working. The hospital is one of them, very, getting invitation from different, people who's interested in artificial intelligence to use what we have as a data that we have it in our system, to give it or to share it with them to start to test and to validate that program. We have a lot of people from Singapore. They have their own programs. We have people from Germany. They have their own programs. And we had some sharing with them. I remember one of the paper that we published with Dr. Rajiv. It is called Retinval, about how to compare electrophysiological programs, how to detect diabetic retinopathy, sight threatening, diabetic retinopathy, and it was comparing the picture that read by the by ophthalmologist and to their it is just held machines, and it was comparable. So I think so it's our future. I think we need to have, as you mentioned before, and recommend to have a research lab focus on these things, so that maybe we invite people who's interested from the universities, from the computer college, and having specialized in program, and they can make ours. It's not that something is not could be done.
Absolutely.
Thank you, Dr. Adel, for a nice presentation and keeping this in mind for future. I think we are optimistic, and hopefully with your talk, mostly we are optimistic, but something that we need to keep in mind, we are lucky in ophthalmology that we have medical and surgical, and we have diagnostic and intervention. And for the intervention, all the time being, we are safe to a certain extent. I'm not sure about the future. But our colleague in specialty like radiology, they are starting to lose their job. So I'm not so skeptical if the people, they will do the same in ophthalmology. So this is a simple comment. But the question is talking about the same contest. Do you think that IA is affected by geographic variant? So meaning to say, this specificity that you showed for a sample of patient will be affected by where you are practicing?
So the thought was when Google started their first project, the whole population they tested were in India, and they had a very two big groups that were actually involved in this study. They were very well organized groups, but generally their thought was you always need to have a more diverse population to get to actually give the best and more sensitive specific results. So the thought was in general that you actually, to get the best of AI, it's a general thought that was discussed in one of the meetings, is that you would develop the AI in that region. So basically you get your whole sample from that region, and then you assess patients from that region, and then you could get probably the best results you actually look for. Because generally getting a software that was tested in a population that was in the States and then saying that it will work here will definitely not be true. They need to test it, and this is what actually brought me into this, because people are approaching us because they want the data. They want to see what our population, and why would they want that? There are diabetics anywhere. Actually, in the States they have more diabetic population than in Saudi Arabia in total. But the reason is because they actually would want to test their model against different kind of population, and then this will make it a better model.
Yeah.
To sum up.
Thank you for this comprehensive review. I just want to ask you, is there any regulations by Saudi authority of data and artificial intelligence? It was established recently, right?
Yeah.
That agency. Any regulation?
So I was surprised yesterday to hear that there was a software that actually got the first Saudi FDA approval. I don't know if any of you heard about it. It's called DRS. It actually took it 6 months ago. Did you know about this?
No.
It's called DRS. It's a software that detects diabetic retinopathy.
But that authority was established just recently, August, I think, right?
No, this is the Saudi FDA.
The Saudi FDA.
The Saudi FDA that approves it.
Yeah.
So basically, it's considered as a medical product. It has to go through the process of Saudi FDA. The AI agency, I forgot what's the name of it.
It's Saudi Authority for Data and Artificial
something
Intelligence.
yeah. So basically, they are looking at it from. Said eh? Oh, okay. Interesting. basically they look into it from legislative part of dealing with it.
Okay.
Medically, it's the Saudi FDA that has to approve it. So they did. What I know is that those got the approval without going to this entity, the Saudi AI entity. They only went to the Saudi FDA and got it from
So
there.
meaning that why I'm asking this is that would
Yeah.
allow us just to export our data outside. It's
Exactly.
Genetic.
So the
You know, it's
government,
like genetic, don't.
the governance on this is not yet there. I asked people who actually work in different entities in the university, in part of the Ministry of Education, where they actually deal with the research all over the kingdom, and they said the governance is not there.
Okay.
Although many of the people who actually work on the top management in the Ministry of Education actually claim to be AI people, but it's not there. So basically, now. I mean, this depends a lot on you making this decision. But if anything comes in the near future, and like you shared the information, and then for some reason it was deemed to be illegal, you're open for liability.
Yeah.
Yeah.
Just to keep in mind. Thanks.
Any further questions? Yes.
With regards to any policies, there is this National Health Information Center, and they have policy for telemedicine. I'm not sure if it is published or not yet, but they allow artificial intelligence use in general. It can be used. This is one of the statements. But there are other regulations for telemedicine that is described in this draft that we should all be aware about.
Usually the validity and compare it how much more than one. Maybe you have 100 programs, but if it's not valid and being tested, it's useless.
Absolutely.
Okay. Thank you very much, everybody. Now we go with the next meeting.
Thank you. Thank you. والله محتاج نطلع.
ايه تحتاج الوصلة؟ ايه اجي كلاس روم 3.